Hello to everyone watching this recording today. My name is Jessica Zaring, and I am the Department of Health's Antimicrobial Stewardship Pharmacist. It is my incredible pleasure today to be talking to you about the topic of interpreting an antibiotic susceptibility testing report, or an AST report. Now, some folks watching this may be more familiar with the acronym C&S report, which stands for culture and susceptibility. Both AST and CNS both refer to the exact same report. Our learning objectives today include learning how to interpret an antibiotic susceptibility test report. The second objective is referring to our practical portion of our lecture, which we typically do not record. First, let's ask the question, what is an AST report? AST, as I've defined it earlier, antibiotic susceptibility testing, is a lab procedure performed to identify which antibiotic is specifically effective for a particular organism. It provides the prescribing clinician guidance on antibiotic selection, and it can be performed on a variety of specimen types. Blood, sputum, urine swabs are probably, and wound swabs are probably the most common ones we're going to see in the nursing home setting. Here is an example of what an AST report looks like. We have on the left column there are antibiotic names. You can see there's many antibiotic names. We'll talk about why we choose the antibiotics we do here for specific bugs in a later slide. We have the MIC dilution. We're going to define that in just a moment. And we have the MIC interpretation column, which again, we're going to define in just a moment. Now we're looking at this report and we're wondering to ourselves, what does MIC mean? Which is an excellent question. MIC means minimum inhibitory concentration. We also call them breakpoints. Now, some folks here may think back to those days in the micro lab where we had all those test tubes, we had our loop tool that we used to swab the agar plate that had bacteria growing in it, and we dipped that loop into different tubes and waited 24 to 48 hours, and we tried to figure out which ones were cloudy and which ones were clear. Essentially, that is the visual picture of minimum inhibitory concentration. It is the minimum concentration, typically micrograms per mil of antibiotic, needed to stop bacterial growth. These MICs are based upon a standard, actually a couple of standards. One published by the Clinical and Lab Standards Institute, or CLSI. The other one is FDA themselves. They have MICs that they have approved for use. What is important to know, let's actually go back a slide here for a second so we can see this visually. All those numbers under the MIC dilution column there are not equal to each other. They are specific for specific different organisms and different antibiotics themselves. Those numbers are used to determine if an organism is susceptible, which is S. You can see that in that right-hand column, the MIC interpretation there. Resistant, which is R, listed again at the top of that column. And I, intermediate. And then there's another one, another category called susceptible dose dependent, which I'm just going to briefly mention. However, you're not likely to see this too much yet. This is one that is currently uncommon. It may become more common in the future as we get more data. Now, the next question you may have on your mind is, how do I read these MICs? These numbers are very confusing, and you're right, they are extremely confusing. What I would encourage is to look at that column that says MIC interpretation right there. That is the lab helping to translate all those confusing numbers into something that can be clinically actioned upon. The MIC interpretation section is going to tell you if that organism is sensitive or resistant to an antibiotic, and that is a section I encourage you to pay attention to. Those MIC numbers that you see in the column that are commonly really confusing, that's going to be something a little bit more for a specialist to interpret, an infectious diseases physician. They can help you interpret those if you have a tough case, for example. Otherwise, the MIC interpretation column is the one to pay attention to. Now, why do different AST reports list different antibiotics? Now, ultimately, in the tested antibiotics list is going to depend on lab policy, but this is a kind of a screenshot of where those antibiotic names come from. The CLSI's M100 contains what are called tiered recommendations for which antibiotics are to be tested on which organisms. Now, looking at the image on the right, you see tier 1. Now, these are the ones that a specific bug is always going to be tested against. In this case, we're looking at Enterobacterales, which is going to include E. coli, Klebsiella pneumoniae, Proteus mirabilis are top organisms that cause UTI. Now you see antimicrobial agents under tier 1, we're always going to be testing for susceptibility to ampicillin, cefazolin, and others as well. Now this table is truncated. There is actually more listed in the M100, but this gives an example. Tier 2 antibiotics. If the lab finds that an organism has a lot of R's next to the antibiotic name, then those antimicrobial agents that are in tier 2 may be what they test for susceptibility to next. And you can see in that list, we have a couple of names in there that may not be so common in the nursing home setting, especially the penoms there, ertapenem, imipenem, meropenem. Those are the broader spectrum antibiotics that we typically reserve for the more resistant organisms. And so that can kind of make a little bit of intuitive sense why we're not testing for those immediately up front. Now, I've also included, just as a reference for you really quickly while we're on that topic of which antibiotics we're testing for, I've included this list of tier 1 antibiotics for E. coli because I know a lot of these names may not necessarily represent antibiotics that we're working with directly in the nursing home setting. Ampicillin, the antibiotic name listed there, is an aminopenicillin. Oftentimes we use in the nursing home setting amoxicillin, not so much ampicillin, and amoxicillin susceptibility can typically be inferred from ampicillin. Cefazolin is a similar vein. Cefazolin, I like to colloquially think of it as IV cephalexin. Cefazolin is IV only, typically used in the hospital, but in settings where we're not using IV too much, we typically use cefazolin susceptibility to infer cephalexin susceptibility. And then I have some other names that are going to be a little more familiar to folks. Now, another question that we may have is, how do we tell if we're looking at a really resistant bug from looking at that AST report? There's a few different ways to look for that. Now, ESBL, for example, extended spectrum beta-lactamase producing organism, is what that stands for. How do we know we're looking at an ESBL in a culture and susceptibility report? Now, these are going to be commonly, ESBLs are going to be your E. coli, Klebsiella pneumoniae, Proteus mirabilis, sometimes as well. These are commonly resistant to the antibiotic known as ceftriaxone and sensitive to an antibiotic known as cefoxitin. Now, a lot of labs will put a statement at the top of the report specifically calling out that the organism is an ESBL. But another way to see if an organism is an ESBL is look at that ceftriaxone. Is there an R next to it? That gives you a little bit of a clue that you're probably looking at an ESBL. Another example is Staph aureus. How do we know we're looking at a MRSA? First, we're going to look at the MIC interpretation column. We're going to look to see, is there an R next to oxacillin? Now, let's back up for a second because MRSA stands for methicillin-resistant Staph aureus. Doesn't stand for oxacillin-resistant. So that can feel confusing. Methicillin is an antibiotic that was more commonly used in the lab setting, and resistance to it was first discovered in the lab setting. Therefore, the reason why we today call it MRSA and not ORSA. Clinically, however, we used oxacillin. Therefore, if it says resistant to oxacillin, you see that R, it's MRSA. Now let's kind of put this together in an example, how we can actually kind of act upon this in practice. Imagine for a second that you're an infection preventionist, you're looking at the culture and susceptibility / AST reports that have just come across the fax machine, and you happen to see a report that looks like it might be MRSA ESBL, and we didn't talk about VRE. I'll quickly define that for you in just a second. But imagine that you see that. Now, what do we do with that. Exactly. One thing to do is if you have a good connection with your consultant pharmacist, you can have them take a look at it, make an antibiotic recommendation. The other thing to do as well is to call up the doctor and just ask the question, is this antibiotic they're currently on appropriate if they happen to be on an antibiotic already? So I gave, for example, another example that might be commonly seen for, you might see a resident being treated with cephalexin for a true and confirmed UTI. That AST report shows that R next to ceftriaxone, and we're feeling concerned that this might be an ESBL. ESBLs are resistant to cephalexin, and therefore it is important to ask that question, is this antibiotic, the cephalexin, appropriate for them? That will cue the doctor that maybe it might be a good idea to just take a look at the treatment regimen, treatment plan, and maybe make a change to it. Now, let me back up to what this VRE thing is. Vancomycin-resistant enterococcus. When you see a report for enterococcus, this one, you're looking for the R next to vancomycin. If there is an R next to vancomycin, it is VRE. Now, again, I just want to kind of qualify and clarify all that I'm sharing with you today. What I'm sharing with you is from a clinician perspective. There may be MDRO notification processes that I am not aware of. It is important to follow those, as I am the antimicrobial stewardship pharmacist looking at this as a clinician. I am not always going to be knowledgeable about MDRO notification processes, but of course, my team or our MDRO team is happy to help support you if you have questions. These are the references that I have here for you today. I'd like to thank you for your time today and wish you a wonderful rest of your day.